Hello, and welcome to today's webinar, Your Medicare Guide, Tackling Costs and Answering Your Questions. I am Liza Averick, Program Director at CLL Society. This program is made possible through generous donors like you. At this time, I would like to welcome our speaker, Syra Sultan.
Thank you, Liza. I'm very pleased to join you all today, and I have the pleasure of partnering with longstanding colleagues, Kay Scanlon at Concilium Strategies, and Giselle Bleeker, a longtime resource for me on Medicare issues, and now a certified Medicare counselor, to answer your questions today. I'm Syra Sultan, President and CEO of Connect4 Strategies, and I also serve as Director of Government Affairs and Public Policy for the CLL Society. I'll start things off with some background and context for today's discussion. Then we'll talk about two new programs. They'll start for the first time this coming January, and a lot of attention has been paid to them, especially for cancer patients and rare cancer patients, as potentially the most likely to benefit from these new programs. My colleagues will keep an eye on the Q&A, so keep your questions coming. If you have questions specific to these two programs, we'll try and get to them in the sections where we talk about them. Kay will field these for us. And then we'll go to your more general questions on Medicare and Medicare Advantage, at which point Giselle will take over. We'll certainly do our best to get to all the questions for the day. So to level set, Medicare is made up of several parts. Medicare Part A speaks to hospital inpatient. That's when you've been admitted to the hospital, say for 24, 48 or more hours. Then Medicare Part B is for hospital outpatient. That's emergency room or when you're there for a much shorter time. And then physician offices, when you go to a doctor's office in the usual way that you do very probably often. Part D, I'm skipping Part C on purpose for just a minute. Part D refers to prescription drugs. And then Part C is a combination of these other parts where you have to buy a specific Medicare Advantage plan. So that's often referred to as Part C, but also as Medicare Advantage. We'll be referring to them in both ways throughout. Both the two new programs we'll be discussing today relate to prescription drugs. So that's why it's highlighted in yellow. That will be relevant to you whether you buy your Part D prescription drug plan in a traditional Part D plan, or you buy your prescription drug coverage through a Medicare Advantage plan. Why don't we start with a poll question here to get us started? I'll read each one and explain perhaps. So I have Medicare insurance for my prescriptions through 1, a traditional Medicare Part D plan, 2, the Medicare Advantage prescription plan, or I don't have insurance through Medicare. I want to offer that as an option here too. Maybe you're attending the webinar for future Medicare learnings. And number 2, if you have a Medicare Advantage plan, meaning that Part C plan, that I just highlighted on the previous slide. Why did you choose this option over the more traditional Part D plan for your Medicare prescription drugs? Is it that cost savings was the biggest factor important to you? Or you kept getting calls from a local healthcare plan and other marketers? Or was it that you really liked the benefits that you cannot get in a traditional Medicare plan? Some people sign up because they don't realize there's a difference. And then finally, the last answer, I don't have a Medicare Advantage plan. And relates back to the first question. Maybe you have a traditional Part D plan or you're not yet in Medicare. In the interest of time, while you're answering, I'm going to keep going because we want to make sure we get through all the content, but also leave lots of time to answer your questions. So this webinar today is not your typical Medicare 101 and the Q&A that's ahead of the annual open enrollment, which you might attend with other programs. While we will take your Q&As, your questions on Medicare in a bit, we are specifically coming together today to talk to you about two new programs that will start next year. Before we get to them, we'll talk a little bit about some context. Those programs will come about because of a law Congress passed in 2023. There are many different parts to that law that relate to Medicare and some that relate to some completely different topics. We've been analyzing the provisions of this law and all its implications for CLL patients for over a year now. And you may have seen different communications from the CLL Society about what we've been doing to work with the Centers of Medicare and Medicaid Services, or CMS. That is the agency that administers and implements the Medicare program, and they are in charge of implementing this new law as well. So our job this past many months has been to make sure that CMS understands our concerns on behalf of CLL patients, where we have them, and make sure that the law is implemented in ways that are most helpful or least onerous for the patients that we represent. So we've been talking about 2 new programs. So why are there 3 boxes on this slide? We see a lot of confusion out there about this first box, mostly in terms of its implications or impact, the way it impacts the second 2 that we're really going to focus on. So I thought we'd take a moment to clear things up, just in case you might be confused too, or just have questions. Let's cue the results of the first 2 poll questions here, if we might. Okay, so it looks like about half of us on the call today almost have traditional Part D plans. A quarter have Medicare Advantage plans. And then 33% don't yet have insurance through Medicare. That's interesting. And then the biggest reasons it looks like for why we joined why people joined a Medicare Advantage plan looks to be you like the benefits that you may not be able to get in traditional Medicare, okay? And the second one, cost savings, was the biggest factor. That's really helpful and interesting, and we'll keep that in mind as we take questions later on in the webinar. Thank you. Okay, so on to direct price negotiation. So this is the part where I'm going to just try to provide some clarity leading into the 2 topics we'll talk about. So for the first time ever, the government has been allowed under the new law to directly negotiate with pharma companies the price of the drugs that we take as Medicare patients. Until now, these prices were negotiated by private insurance companies that you've been buying your prescription drug coverage from. So the government doing this directly will start slowly. In the first year, there will be just 10 drugs negotiated. These will be the most costly to the Medicare program, not to you, the patient, but to the Medicare program. The government negotiated with the pharmaceutical industry directly in these cases. And on the next slide, you'll see the White House. This is actually a tweet from the White House itself. You can see their little logo in the upper right-hand side. Of the 10 drugs that the government stepped in to negotiate, one of them directly impacted CLL patients in this very first go-around of 10 drugs. The White House in this graphic wants you to know that the pharmaceutical company charges a list price of almost $15,000, but that they negotiated and got the price down to about $9,300. So why is this a point of confusion when it comes to our topic of out-of-pocket costs? We've had a lot of questions ever since this new price of $93.19 has been announced about what the implications are for our patients. And it's really weird to have to say there is no direct impact to the patients. The direct impact to your own out-of-pocket costs will be something we'll talk about here today. And now in this segment of the program. So what is the price of Imbruvica got to do with your out-of-pocket costs, if you are a patient taking Imbruvica, that is? It seems, as I said, logical that people think that if the price was once higher and is now lower, that they will pay less out of their own pockets. This is wrong, and here's the confusion. In mid-August, the first set of prices were made public, including this one for CLL patients. Yes, other people will pay less, the government will pay less, but not patients necessarily. The savings aren't trickling down, at least not directly or immediately in the ways we may think. They trickle down, perhaps some might say, in this program of out-of-pocket costs. So on the next slide, this is a very complicated slide, but believe it or not, if we pick it apart and look at one column at a time, it really is all we need to look at to understand this new out-of-pocket cap program. This program will make sure that after patients pay their premiums the rest of the year, they'll pay a max of $2,000. Let's take a look at this graphic in small, digestible pieces. What is an out-of-pocket cost? Again, this seems like an obvious answer, but it's not a direct reading of what you would think. So an out-of-pocket cost is partly what it sounds like, what you as a patient might pay out of your own pocket. But it does not include the purchasing of the program, of the health plan itself. So the first thing you do the first time you pull out your wallet, so to speak, is when you buy a Part D or Part C Medicare Advantage plan. That's the premium. That's not an out-of-pocket cost, at least as defined by the Medicare program. So whether you're looking back at 2023, as this column in this slide does, or you look ahead to next year, the premium is not included in a definition of out-of-pocket costs. Will they change the premiums? Yes, they will. Perhaps directly because of this new law that's passed, and Giselle will talk more about that in her segment. The things that are out-of-pocket costs that relate to this new program that will kick off in January are the things that you see here in this column in orange. And let's go through those as we dissect this column. So in 2023, before the new law was passed, the insurance policy you bought basically had 4 stages that you went through. First, you met your deductible, where you typically paid everything. That's in orange. You often hear about people getting hit pretty hard at this stage, sometimes not able to afford their drug at the pharmacy counter. Some plans don't have deductibles, but if they do, in 2023, the maximum deductible a Part D plan could charge was $505. Then there's the, quote, initial coverage stage, where the patient is picking up about 25% of the cost. Again, see the orange part in the next section up. For CLL or other rare cancer patients, we often found our drugs on something called a specialty tier that made us pay 1%. And that cost sharing could be anywhere from 25 to 33% per drug. Then in the next stage, there was the infamous coverage gap or donut hole. And then finally, the catastrophic stage. And even in this last stage, patients are left paying 5%. I'm putting aside low-income subsidies as an anomaly, and we can certainly take questions on that. But for the average patient, we were still picking up 5%. And since that obligation continues till the end of the year, there's really no point in the year when the patient is ever really done paying. So even just that 5% can be onerous for many patients, especially in cancer, where drug costs can be quite high. Let's do a poll question so that we understand going into the next section here what folks are facing with themselves. And in the interest of time, we'll keep moving while you're answering the question. But if we could put the question up, do you, and I will again read it, do you know what your out-of-pocket costs are now that we're defining out-of-pocket costs for all of us? Remember, it's not the premium. It's not what you pull out your wallet to first buy the healthcare plan. But during these orange stages, if you will, do you know what your out-of-pocket costs are for your prescription in Medicare Part D or Medicare Advantage plan? Your choices are yes, I know what they are, and they are well over $2,000. Yes, I know what they are, and they're below $2,000. I don't know what they are, but they do seem very high. No, I don't know what they are, but they're manageable. And finally, for some of us on the call today, we don't have a Medicare or Medicare Advantage plan. Now let's go to 2024, the year that we are in now. We actually saw some changes from the new law that you may or may not have already noticed in 2024. The donut hole or the coverage gap was eliminated. So we have gone from 4 stages of your insurance policy throughout the year to 3. Now you just go from initial coverage where you pay 25%, or as I said earlier, 25 to 33% if your drugs are on a specialty tier. And then you move right on to catastrophic. And you may have noticed that in catastrophic, this year, you are no longer responsible for that 5%. And so when you begin to pay nothing in that catastrophic stage, the reality is that even if we don't yet have this new program, this cap on out-of-pocket program that starts in January, you essentially were capped at $3,250 this year. There are some exceptions to that, like if a lot of you rely on generic drugs, and we can certainly field questions on that. So finally, now that we understand the world before the law, the world in which we live today, initially with the law, let's turn to 2025 and what to expect next year. Now the out-of-pocket program will be kicked in officially starting in January. If it hadn't existed, by the way, our out-of-pocket costs effectively would have been about $3,400. But you can see in the red bar that with the new program, patients will be capped at $2,000. Now, again, just to remind everybody, you're still having to pay out of your own wallet, I'll say, the health plan, the Part D plan or the Part C or Medicare Advantage plan with your own money. That's the premium, not part of the out-of-pocket calculation. So again, for out-of-pocket, focus on the two remaining orange boxes in this last column. So let's cue the results of that last poll question and see how people fare compared to this new 2,000 cap. So a good quarter of us are paying out-of-pocket costs well over $2,000. About a fifth of us are paying below $2,000. That's interesting. And it looks like just over 10% find that those costs are manageable, and just under find them to be too high, even if they don't know exactly how much they're paying today. Okay, so for the 25% of us on the call today who thinks that who understand that what their out-of-pocket costs are and think that they are well over $2,000, well, this new cap, this new program that kicks in January is really good news. This is also the year, 2025, January, where Imbruvica's government negotiated price will kick in. Remember that number, it's about $9,300. So the 25 to 33% cost sharing should, in theory, be helpful to patients. Some estimates indicate that 20% of Medicare beneficiaries are likely to spend enough out of pocket to hit the new $2,000 cap. And those numbers sound like they're pretty close to the numbers we cited in the poll question just now that you all answered. Rare cancer patients are more likely, and that too seems to be true since we're just on this call alone, closer to 25% of people who will benefit from this program. So this is why the new $2,000 cap, rather than the lower price of Imbruvica, even if you're taking Imbruvica, is the reason patients may spend less for their care. I really think that's a point worth resonating on one more time. I want to repeat that and say, you might see that a lot of CLL Society's work this past year and going into next year has focused on the out-of-pocket cap more than it has on the price of Imbruvica. And that's because of what I just articulated, that it is going to be this program on out-of-pocket caps that will be meaningfully different for our out-of-pocket costs for patients than the lower price of Imbruvica. I want to pause here and invite Kay to see if there's any questions on this specific topic of out-of-pocket caps. You can continue sending in your questions if they occur to you later in the program, but I just want to stop here for a second and see, Kay, do you have any questions on this topic?
Well, we have a couple questions that are fairly general, and then we have several that are on this topic or on your previous topic.
Let's focus
If
on
we
the
wanna-
ones related to the out-of-pocket cap. What do you have there?
Okay. Will the deductible of $590 in 2025 be in addition to the $2,000 max? So essentially, will you pay $2,590? And that's a simple no. It's $2,000, including the deductible.
That's right. The
The
only thing it does
next-
not include, everyone, is what you paid to buy your Part C or Part D plan. But if it's your deductible, if it's your cost sharing in the initial coverage phase, that does count, as Kay just said, in your $2,000 cap.
Okay,
Another question,
the next
Kay,
one
on
we
this
have-
subject? Okay,
sure do.
all right.
And this one's for you, Sarah. Is this program in jeopardy depending on the outcome of the election?
I certainly think that there will be some folks that will want to roll back the IRA, the Inflation Reduction Act, which I talked about in an earlier slide. But it will also depend, of course, not just on the presidential election, but the congressional elections as well. So we will be watching very closely at CLL Society, monitoring both elections and thinking about how the elections impact CMS, because for now, this is already law and being implemented. But I would say watch this space as we learn more. A little bit more fine print, I would say. I'm sorry, Kay, was there another one?
There are more questions. Yes, this is fantastic to have a lot of questions on this because it is confusing. In 2025, how can the out-of-pocket spending, and this is for Giselle, spending be $3,400 when the out-of-pocket spending cap is said to be $2,000? So the threshold versus the OOP cap.
Yeah, I guess people were listening carefully, and I love that. 3,400 is what it would have been had this new program not kicked in. So with the new program kicking in, we are not going from 3,250 to 34 and change. We are going to 2,000. And that's what that arrow indicates between 2024 and 2025, between the two red banner numbers.
And another question, what does spending threshold projected to be $8,100 in 2025 mean in the footnotes? I think you answered that, but
it relates to the
as
generic drugs. So if you are taking, I'm sorry, Kay, were you about to answer? Go for it.
No, it's what what the spending limit would have been. And in 2024, for example, the manufacturers are covering part of that, and the 5% in the catastrophic phase has been phased out. So some of these discounts that the Part D that the manufacturers are required to pay count toward meeting the threshold, and that's why there's a difference between the threshold and the anticipated out-of-pocket expenditure for patients. And we have just a couple more. We have, let's see. Okay, if the Part D plan in 2025 are covering 60% of the costs above the spending cap, won't that create issues in getting approved for more expensive medication?
Go ahead, Kay.
Yep. It's interesting. And that's something we always worry about. And that's something that CLL Society is really pushing in every time engaging with CMS to say, look, in Part D, you're supposed to have protected classes, and cancer, it's a protected class. And when I say protected class, what I mean is that they're supposed to pay for and cover all and put on formulary all of the drugs in those protected classes. They're also supposed to have any of their step therapy protocols or other things and tricks and games that they play are supposed to be based on evidence. So again, that's something that we always worry about. And you can expect that sometimes if you've got different classes and one class is particularly inexpensive and there's no clinical guidelines saying that the more expensive one is better, then you might have a step therapy. But CLL Society, as I said, is really, really pushing to hold the Part D plans and CMS's feet to the fire on that one.
And this place, and here I might pause also and throw in that CLL Society, please keep watching the website because we are planning on some sort of a platform for our patients to be able to report in starting in January. Not problems you've always maybe faced with Part D or Part C plan that you've had, right? Because some of these insurance step therapy, prior authorization has always existed. But to the extent you're seeing something new and different, it would really be helpful for CLL Society to be hearing from you all so that we can in real time be not only talking to CMS like we're already doing, as Kay mentioned, but talking to them about what's happening in the real world in real time for our patients so that we are speaking with more and more credibility about not a theoretical problem, but a real one. So do please keep an eye out for communications from CLL Society and watch this space for a platform like that.
And there's one, or actually a couple of related questions. And because we're highlighting Imbruvica, we've kind of created a little bit of unintentional confusion on what does this out-of-pocket cap and everything apply to. So when we're looking at Imbruvica, we're talking about Imbruvica because that was the selected drug for the last negotiation. When we're talking about the out-of-pocket cap and, later talking about smoothing, that's all drugs. So it doesn't matter. It doesn't matter whether you're taking Imbruvica or Imbruvica and 20 other prescription medications, your cap is going to be your cap. And the Imbruvica example is used because it's the one where the price was negotiated. So later we can show what, if any, impact the negotiation is having on out of pocket.
This cap does not apply to other parts of Medicare. So this $2,000 is relevant to your Part C and Part D plans as it relates to your prescription drugs. If you are seeing a physician in their office and you're paying a copay, for example, it does not apply to that. We had a question earlier that was submitted before the webinar began, and this might be a good place to answer it, is that this does apply, since it applies to all prescription drugs, as Kay mentioned, it doesn't just apply to people taking Imbruvica, it applies to all drugs. And a question came in earlier saying, is it applied to all drugs in total? Meaning it's not $2,000 for Imbruvica, $2,000 for XYZ CLL drug and ABC CLL drug. It applies to all drugs, including your statin. If you're taking a statin or taking a drug for anything else, even though it's cheap and it's just $10, it applies to that as well.
Yeah, this is just, I may just jump in that of course this would have to be covered drugs. So these have to be drugs that are actually covered by your formulary under the Part D plan. If it's not a covered drug, it doesn't count towards the $2,000 out of pocket.
Very important clarification. Thank you. This $2,000 will also be indexed to rise at the rate of growth in per capita Part D costs. So this number will change over the next few years. So by contrast, while out of pocket, the program kicks in January and you have to do nothing to qualify for the program or to benefit from the program, smoothing is a different matter. This one, you must sign up. So it's really important to pay close attention to our conversation today, but also to maybe the regular mailings you get from the Medicare program, and you're used to them and you've been, you know what to expect. You maybe throw it in the trash before you even read it. This time you'll want to read it because this will be where you will sign up for the smoothing program. So for that reason, I'm going to start with 2 poll questions that will get you thinking about your own circumstances as you listen. Okay, once again, I will read them and then keep going so that we have time to answer all these great questions coming in. The first one, do you face higher costs for your drugs at the beginning of your plan year before you have met your annual deductible. So yes, I do, and those first few times at the pharmacy counter can be painful, meaning that you're paying $1,000, $2,000 right at the outset when you first walk up for your very first drug and your deductible has not yet been met, which means you're picking up 100% of the cost. Yes, you do face higher costs, but those initial outlays are manageable. No, I have a very low deductible in my Medicare plan. And finally, no, I do not have a Medicare plan for my prescriptions. And relatedly, the second question, if you could spread those higher costs for your prescriptions before you've met your deductible, say over the entire year or even part of a year, could you take the time, or would you want to take the time to fill out the necessary paperwork, meaning to spread those costs out over the course of a year? Simple answers, yes or no. This program, known as the smoothing program, or other times called MP3, the Medicare Prescription Payment Plan, is, again, remember, your premium to buy a plan for 2025 to insure for your prescription drugs is already paid. Likely you paid it in 2024 as you selected your plan and locked in. You're down to 3 stages, remember, a deductible, initial coverage, and then catastrophic. The $2,000 cap is in place, right? It's January 2025. Imagine you're there. But what if the first out-of-pocket cost is over $1,000, and that's a lot to swallow all at once, right? How many of you see this and feel this? About $150 if you're incurring costs of about $150 a month, and you eventually hit $2,000 down the road, that's maybe less painful. But in March, if you suddenly have an out-of-pocket cost that would have been, say, $5,000 for one drug alone, maybe even, but now it's $2,000 because of the cap, it's still a lot for many people. Can you anticipate that and make time to enroll today or soon when Medicare makes it available to enroll in this new program? Then most people pay for the premiums on a monthly. Oh, so let me pause there and say that's what this new program will allow us to do. This smoothing or MP3 program will allow patients to spread that $2,000 over the cost of the year. As this slide notes, patients have to proactively sign up. Why is that? Unlike the other program. Well, the insurance company that you're buying your Part C or Part D plan from don't really love the complications that come with giving you the option to spread that $2,000 over several months. It's a hard program to administer, perhaps, and so they're not that keen on it. And in this case, as my slide says, Congress caved to the insurance companies and made it a little more difficult by making patients proactively sign up. This program has been hard to explain, hard to think about how to implement. CLL Society has spent a great deal of time with CMS trying to make sure it happens in a good way, not just that the program be administered in a good way, but it be communicated about with patients in a good way. So some people have tried to liken this to a monthly credit card payment. Other people talk about it like running up a tab at a bar or a restaurant, if you will. There are different places where this is similar and where they're different. So like a tab at a restaurant or bar, perhaps, there is no interest for the patient. So if you don't pay it all at once, the $2,000 because you signed up for the program and the cost is being spread over time, do you pay a little extra every month in interest? No, you do not. High costs hitting mid-year and not benefiting it as much. So this is an interesting one. Let's say you're paying for a statin for several months of the year and the copay is pretty low. Then you get suddenly hit with a high cost drug. Let's say that $5,000 drug I spoke about, but you are on the hook for only $2,000 because of the cap. And that $2,000 hits mid-year. Do you get to spread the cost of that out for an entire calendar year or an entire 12 months? it's really only spread across the remaining months of your insurance plan year. So let's say your insurance plan year runs a calendar year. If you incur that cost in May, really you'll only be smoothing those costs out, spreading them out between June and December. So that's a little bit different than a credit card bill, for example, that continues to spread the costs out. In this case, like a credit card bill, perhaps, the monthly amount will keep changing. So if you go to that example of where I mentioned that maybe you only incur costs for a statin and a few other things, and your monthly payment is about $150, and then suddenly in May, you get that much more expensive drug. Now that will keep being added to your bill for the remainder of the year. Or let's say you start out the opposite. You start out with $1,000 tab and you're spreading that out over the cost of your 12 months. You got hit with it, let's say, just in January. Now you add a statin in February or March. The next month, what you owe under the smoothing program will be a little different. Let's say you add another drug. It will be a little different yet again. So you're continuing to add up a tab, if you will, as you go along, and the payments get spread over shorter and shorter periods of time, meaning only till the end of that calendar or insurance year. One thing to watch out for, if you are already paying your premiums on a monthly basis, which many people do, usually from Social Security payments, those monthly payments are separate and different. And it's really important to keep those in mind as a separate amount. And I'll come back to that yet again. The other thing to know, you can cancel this payment plan, the smoothing plan, anytime you like. If you just want to go back to paying it at the pharmacy counter, if you will, the full amount due at the moment, like you do now, you can cancel it after you enroll and go back to doing it the way you've always done it. We expect for our patients that we will likely see everyone incurring an out-of-pocket cost well above $2,000 right at the start. Whether it's Imbruvica or any other drug that a CLL patient takes for CLL, these are expensive drugs. These are not statins. And so CMS has created this, quote, likely to benefit category. What that means is in the communications you get from CMS about this program, you might see language that says you are likely to benefit from the smoothing program, or we think you may be a person likely to benefit from this program. We think from our own assessment of CLL cancer drugs and their pricing that you're almost inevitably going to benefit from this program, which is why we wanted to take the time to hold this webinar today, in large part to remind everyone or to let everyone know it's very important to sign up. And if you look at the next slide, you'll see the calculations or the drugs that we have been looking at on everyone's behalf. So this drives home the point that Kay made earlier from the question. It's not just Imbruvica or ibrutinib that is subject to this out-of-pocket cap or to the smoothing program. And this slide is also meant to drive home the fact that whether it's a negotiated drug, right, whether the government directly negotiated the price of this drug with the manufacturer, as in the case of ibrutinib, or whether it's any other of the drugs that CLL patients likely take, whose price is still set for Medicare patients the way it's traditionally been set and not through direct negotiation. What matters most to our patients is likely to be the $2,000 out-of-pocket cap. So, as I've mentioned, CLL Society has been analyzing and assessing the implications of this law for months and months and months at this point. They have been fighting for details that support our patients. Some we have made progress on, some we have not yet made progress on. Everyone pushed hard for auto enrollment before the law was even passed so that you wouldn't have to proactively enroll in the program. But we are now, since Congress did not manage to do that, we are now fighting hard for auto renewal. We're fighting for longer grace periods in case you weren't able to make a monthly payment. We're fighting for communication early and often. I won't go through all of these because I'm seeing we're running low on time and I want to get to all your questions, but these slides will be up on the website afterwards, as Liza mentioned. On the next slide, we have also been paying attention to the issues the questioner asked earlier. Will the patients have to step through Imbruvica first because it was one of the negotiated ones? Or will patients be encouraged to take anything but Imbruvica because they were not negotiated, which means that perhaps the health plan or the middlemen made more money on those? These are all things we'll be watching carefully. Okay, so on the next slide, let's queue up the results to the last two poll questions we asked. So did you face higher costs for your drugs at the beginning of your plan year before you had met your annual deductible? Interestingly, just about a quarter in both instances said yes, and those first few times at the pharmacy counter were painful. Another quarter said yes, but they were manageable. And then on the second question, if you could spread those costs out, interesting that only 40% said no, 60% said yes. So that's really helpful. For that 60%, then please pay attention to the fact that even if you don't think you might benefit actually at first, you may find it useful, and you may decide that you want to carry on doing it if you try it. So whether you think you benefit or not, highly encourage people to, one, follow CLL Society and stay updated as we learn more about how to enroll. We'll pass on that information to you, but two, look out for yourselves for communications from CMS this year on how to do it. Remember to stay in touch. We will be posting some information on the platform so that you can keep letting us know, yes, I'm benefiting from this program. I'm so glad I signed up. No, I tried to sign up, but it was really difficult, and here's why. Or I'm not able to get my drug Imbruvica or some other drug that I want to take without all these new hurdles that I've never faced before. All these things will be things that will be really helpful if you continue to communicate with the CLL Society on these. Okay, now I'd like to queue up Kay first for smoothing questions, and maybe in the interest of time, suggest that we go ahead and open for both Giselle and Kay to answer questions now that have been coming in from the audience. So if Giselle and Kay will join me on camera, that would be great. And let's start with questions either one of you has and wants to tee up.
Yeah, actually, I'm just going to jump in very quickly. So as Sarah mentioned, I'm a certified Medicare counselor, and I work for my local state health insurance program, SHIP, SHIP. And that's a program that runs in every state and in most counties that's government funded to help people get information on how the Medicare program works. So one thing that I recommend for the audience here is after September 15th, because after September 15th, all the new rates for the prescription drug plans that will go into effect in 2025 will be loaded into the Medicare Plan Finder. And that, if you Google Medicare Plan Finder and you go on there and you look for prescription drugs, and I would recommend that you make a little account and you load all your drugs in, and then it will show you what the costs will be across different plans offered in your zip code in 2025. And I recommend highly that everyone on this call go and do this analysis after September 15th, because we don't really know how all these changes are going to impact sort of the formulary and cost sharing by drug. So by doing this analysis after the 15th of September, it will tell you exactly how your costs will change in plan year 2025. So I just wanted to make that quick.
And I want to clarify, when Giselle means your costs, it's not that the $2,000 cap won't be in place or the smoothing program will be in place. It's gets to that, what do you pay out of your wallet for your Part C or Part D plan, right? Your premiums. And then to the earlier questioner's point, will it be harder or easier to get certain drugs? Those
And
are
it
the
should have
things.
on there the prior auth requirements, prior authorization. It will have sort of the utilization management techniques that the plans use to control costs. So it will give you a feeling for if some plans are being, very restrictive on the drugs you take or not, and if they're even covered. So they should be, but we don't really know. I just think everybody should go and run this analysis and make a decision that's right for you.
That's
Based
helpful.
Yeah. And so you can either do it on your own on Medicare Plan Finder if you Google that, or you can call your county/state's SHIP, SHIP, State Health Insurance Program. And they have Medicare certified counselors who can help you run the analysis if you don't feel comfortable running it on your own.
Thank you.
Sure.
Okay, let's get to the sub questions. Okay, Giselle, anyone see any questions that you can help answer?
Yes, indeed. One thing I think we need to clear up is when we talk about drug costs, we're talking about Part B drug costs. So if you are getting your drugs infused at the doctor's office, in an outpatient hospital, in an infusion center, that's under Part B. And the $2,000 cap does not apply to that. So
Right, we're talking about prescription drugs that you get covered under Part D like David or C like Charlie.
right. And there are a couple people, Giselle, who have asked if they don't take any expensive medications right now, or if they're on watch and wait and may or may not be going on treatment this year, should they just kind of prophylactively sign up for smoothing in case? And
Yeah.
how do they make that decision?
Yeah. So I was just looking up the rules. So the smoothing, it's a brand new program. It's starting January 2025, and they're kind of rolling out the rules now. So we're kind of all figuring this out as we go along. But it turns out that you can opt for smoothing before the beginning of the plan year. So the plan year is usually like January is when it usually starts. So you can sign up before, or it says you can sign up any month of the plan year. So you can make this smoothing. Sorry, I had this example of, mid-year, all of a sudden you have a big cost. You can sign up at that point for the smoothing. So you don't have to proactively sign up for smoothing before you really need it, if you need it. So you can just sign up once you know you need it. And then the remainder of the months you can smooth.
And what we're hoping is when you sign up like that, let's say you're hit with that high cost and you're at the pharmacy counter trying to pick up this drug, and now it's a very high cost, that we're trying to make it in as we have advocated as CLL Society to push for making that happen in as real time as possible. But I would not doubt that there'll be hiccups in the first year.
Yeah.
And so you may end up leaving the pharmacy counter without your medicine at that point. So be aware that it might take you 48 to 72 hours, maybe longer, with hiccups in that first year. So just factor that into your decision on whether to do it proactively right at the beginning of the year or not. Other questions, Kay?
Yes, there was another question about use of manufacturer coupon. I believe it was manufacturer coupons. It said company coupons, so I believe that's manufacturer coupons. Can you use, and Giselle, if you
Sure.
want to.
Yeah, you're not allowed to use them with Part D. That's the bottom line. So you can't use manufacturer coupons against your Part D plan. It hits the anti-kickback statute. So unfortunately, you cannot use them with Medicare. Somebody did ask in the chat where they can go to find Medicare Plan Finder. In your search bar on your whatever browser you use for your computer, type Medicare Plan Finder, and that will bring you to the website where you can run your own analysis of your drugs. Okay.
The other thing people are wondering is what impact the smoothing, the Part D benefit redesign with the low out-of-pocket cap and everything else, how much of an impact will that have on premiums? And my guess is that I don't have a guess. Some people are saying they'll go up, some people are saying they'll go down. So some pieces of the puzzle would tend to push them down, other pieces of the puzzle push them up. I don't know if anybody has thoughts.
I'm not sure it's worth like even speculating, because we're going to know like September 15th, right? Around then, all the files are going to be loaded that will have the actual cost for 2025. And you just go, you need to run the analysis using the Medicare Plan Finder, either you directly or working with a SHIP or with a family member, because we don't really know. And that will tell you premium, deductible, cost sharing, if your drugs are covered, if they're prior authed or not. We'll tell you everything. So I think it's just worth, waiting, to mid-September, and all the answers will be there.
Thank you. Any other questions, Kay?
I'm looking through them right now. Let's see.
There's a lot of discussion about the smoothing. And again, this is this is a new program for the insurance, the Part D plan. I mean, it's new for everybody. So the idea is kind of like layaway, as Cyrus said, you can't quite afford that refrigerator now. And so you make, $200 payments every month, to get your fridge. So it's the same kind of idea that they just want to smooth out the costs over time. And so the Part D plan is going to be your creditor. They're the ones who are extending credit to you for that smoothing. And they're going to be sending you the invoice for what you owe for the smoothing. And so it doesn't go to Visa or anything. The debt is owned by the Part D plan. And I don't know if, Sire, if you've been following this, like if they can sell that debt or what happens if someone doesn't pay.
Yeah, I think they can. So that's two important things right there. It's funny because whether you try to think of the layaway analogy that Giselle just used, or the credit card analogy, or the tab at the bar, no analogy seems perfect. So I want to just clarify, in the layaway analogy for the refrigerator, of course, you can't walk out of the store with a refrigerator until it's paid, right?
That's
So
true.
in this
Yeah.
analogy, so the one caveat is you walk out with your drug right away from the CVS counter, let's say, or whatever pharmacy you go to. The other half of the question is you don't pay anything at CVS. Very important to clarify. When you walk into the pharmacy to pick up your drug, you pay nothing. You walk out with your drug. And that's because your health plan, United, Blue Cross, whatever, has already paid for the drug for you. And as Giselle mentioned, the debt you owe, the money you would have paid at the pharmacy counter, is now one that you will pay to the health plan itself. They will bill you. They will make the calculation of how much you owe on a monthly basis. And as it changes every month with a new drug and a new drug that you pick up at the counter and walk away having paid nothing at the counter, they'll keep adding to your tab, if you will, and changing that monthly amount. And it's to them that you owe it. The point about if you don't pay, so there will be a grace period. And there'll be certain, circumstances that will justify your missing a payment, for example, and you'll get a grace and you'll be able to pick it back up. If you don't pay, they can kick you, the health plan can kick the patient off the smoothing program. They cannot kick you off the Medicare Part D plan, the one you bought where you used to pay at the pharmacy counter, and now you're spreading costs out. They cannot kick you out of that underlying Part D program. That's a really important thing to keep in mind. So you go back to paying at the pharmacy counter. You still owe that debt to the health plan, but you continue to have the health plan cover those drugs. You just go back to paying them at the counter, and you have this outlying debt that you need to take care of. So I hope that answers that question. Okay, we have just a few minutes left, so I have to stop here for just a second, and I'd like to just do a quick round robin of closing thoughts. Giselle, could I ask you to go first, maybe?
Yeah, well, I don't want to, beat this to death, but, I really highly recommend that everybody go and do Medicare Plan Finder or call their local SHIP, SHIP office. Just put it in the Google or whatever you use for getting on the internet, and you can find them and running an analysis after September 15th for you to get a feeling for how this could impact your drugs.
Great. Kay, closing thought from you.
Yes, I saw a bunch of questions asking about Medicare Advantage and some kind of querying. Okay, so, for cancer patients, what's better, Medicare Advantage, fee for service. I know that you've got another webinar, we've got another webinar coming up to discuss that. I think that one of the things that, people have said that's good about Medicare Advantage is they have a lot of bells and whistles that are probably really helpful for people who are healthier, perhaps. They do have sometimes fairly narrow networks, and that's one of the things that people struggle with. But I believe that's
Yeah, okay,
stuff-
thank you for that. We are in fact talking with CLL Society about doing another webinar specifically on that topic of Part C versus Part D, traditional Medicare versus Medicare Advantage. And it's nice to see the questions have come in about that, because then we'll go back to CLL Society and talk with them about hosting a webinar around that specific topic. So thank you for that. And then maybe my own closing thought would be also beating a dead horse a little bit, maybe, is that please keep an eye out for signing up for this program. The health insurance companies that you're buying your Part C or Part D plan from are not motivated to have you enroll in this program. It's really incumbent on you to look out for the communications. CLL Society has been working very hard with CMS to make sure that those communications are coming early, often, in multiple formats, in multiple languages, so that everyone has a chance to sign up for this program who would like to. Okay, on the last slide, I want to make mention of a more general webinar coming up on Medicare 101 that another patient group that CLL Society works a lot with, Triage Cancer. So we'll put these slides on the website, and you'll be able to scan the QR code to register and attend. That's coming up on September 26th at 11:30. And then finally, I'd like to make mention in the last slide, thank you so much for joining us today. Please remember to complete that event survey and provide your feedback to help us and also CLL Society plan for future events. Again, this webinar was recorded and will be available on the website along with the slide deck. If we did not get to your question today, please send your question to this email address, support@cllsociety.org. Again, if we did not get to your question today, please send your question again to support@cllsociety.org. And then please remember to join CLL Society for their next webinar, Beyond Your CLL Diagnosis, Comprehensive Health Management, on September 17th. And please remember, CLL Society is invested in your long life, and you can invest in the long life of CLL Society by supporting their work. Thank you so much.